Our topic today for discussion is lumbar degenerative scoliosis in adults. So this is a 67-year-old male, severe back pain, buttock pain bilaterally, bilateral leg pain, and also a feeling of his right leg feeling and numb and almost a dead leg when he walks. So he has difficulty walking longer distances because of it, in addition to the pain. He was a smoker. He stopped smoking in preparation for the surgery. He had done all the usual non-operative stuff, injections, physical therapy, different types of injections. Past medical history was significant for diabetes, dyslipidemia. Well, obviously with that, he does have some considerable medications that he's on, specifically blood thinners as well as medications for his diabetes. All right, these are his x-rays. His pelvic incidence is 64. Lordosis is about 15 degrees. He's definitely got sagittal malalignment. He's quite forward. He does have degenerative scoliosis, mild in the thoracic, a little bit more in the lumbar spine, measuring about 46 degrees. His main issue really is he cannot stand up straight. You can see that he's really compensating from his thoracic spine as well. His thoracic spine is quite flat. And I think we talked about that, Scott, in your case earlier on, about paying attention to what's happening to the thoracic kyphosis. So he's really compensating from his thoracic spine, straightening out that kyphosis in the thoracic spine to be able to stand up straight. And these are his full length. And here he's holding on to the bar in the front, so he's really trying to push himself back as well to stand up straight and in that retroverting his pelvis. But he's still so he's compensating from his thoracic spine, his pelvis, his hips, as well as his knees. You can see he's got his knees bent as well a little in order to compensate. And as we keep moving, supine films, again, the degree of scoliosis itself is not major. He's got multiple segments of degenerative changes. A bit of a closed end. This is a common theme that I think we have seen in most of the cases today. Which is very common. L3, L4 lateral asthesis, and then with that stenosis of that segment is quite common in a lot of these patients. So he also has a substantial, almost like partially subluxed L3, L4 level here laterally. DEXA scan was quite reassuring. Now I do get QCTs on all my patients, even if I have a DEXA. You can see the QCT score in the lumbar spine is very different from the DEXA scan score. And I do want to pause here for a second and maybe have you guys comment on that as well in terms of what you would do with that information. But because of what I've been seeing, I get QCTs on all my patients with pre-op, and I do trust QCT more. Sig?
Yeah, Zishan, I'm really glad you pointed out that almost a contradiction between what the DEXA scan showed and the QCT. So in our patients with osteophytes and our patients with deformity, the DEXA is certainly not going to be reliable at the level of the spine. There is a better correlation at the hips. But having said that, with either a QCT or with measuring Hounsfield units at the vertebra, we can get a much better site-specific information. Our bone health center also prefers the QCT, especially when evaluating the spine patients. I think this is just a dramatic example of the difference when you think about preoperative optimization. Based on that DEXA, you might not have done anything, whereas in this patient, you're probably going to want to put them on an anabolic for some period before surgery.
Yeah, absolutely. So, this is what's really changed my practice. At this point, I tell my nurses know to get this QCT as soon as we talk to the patient about potential of surgery, because we just see so many patients now where it just completely goes in the opposite direction of the DEXA, and then we have to, start them on anabolics and delay that treatment. So now this is almost the first thing I get as soon as once I see the patient and think they need surgery, I talk to them. Well, before we finalize stuff, let's get a QCT.
So
And go from there.
are correlations between DEXA and Hounsfield units, when we look at the lumbar spine, the R value there is about 0.7. So it's a good but not perfect correlation for DEXA and looking at the Hounsfield units at individual vertebra. Have you looked at the correlation between QCT and Hounsfield units? And what I mean by that is that oftentimes an adult deformity will have an opportunistic CT scan where we can measure Hounsfield units. How close is that compared to QCT?
So great question. So the point number one, I don't have a number spared for you, but I will tell you that it does, just based on, as I measure all my patients, I measure the Hounsfield as well. Based on the Hounsfield, the correlation is quite high between Hounsfield units and QCT. Problem with the Hounsfield units is that you cannot yet use it for all insurances to justify treatment. So QCT, because the insurance needs to see that T-score. So that's the benefit of T-score. So QCT, that gives you that T-score, and we have been very successful in getting a treatment for all these patients approved from insurances and all the for that purpose with the QCT that shows the T-score. Now we're not actually, so this is not a separate QCT now with most of the newer PAC system and their softwares. You can get this based on the same CT scans that you have, as long as it's a dedicated lumbar spine CT. So I'm using that as my lumbar spine CT that I'm going to use for my pre-op planning anyway, because, when I use the robot. And so the same one is used for as QCT, or if someone comes in from with an outside one, we can get it off there as well, because the newer PACS packages can get a QCT off any lumbar spine CT that you bring in. It doesn't have to be a dedicated, standardized QCT.
I'll just add to this briefly, Zishan, because it's such an important topic that you're right. Oftentimes, the DEXA will underestimate bone density problems, as we discussed. In terms of this, maybe a U.S.-centric issue, I know we've got a very international audience here, but in terms of getting a justification for anabolics, adding either the trabecular bone score to the DEXA, that changes the numbers by about 20%, or even beyond that, using a FRAX score. And if you've got a risk of a major osteoporotic fracture of more than 20%, then that's a threshold that generally justifies the use of an anabolic. So there are some other techniques beyond DEXA that may justify adding anabolics.
Oh, great point. I think it's important to have a partnership with your bone health program, or if you don't have one, with your endocrinologist, to make sure that they understand all these different things, because a lot of it specific to spine, that information is not widespread. So, excellent point, Sig. Thank you. Bob, I think you were unmuted. Do you want to say something?
No, hey, Sig actually asked the question I was going to ask about correlating those
Perfect.
two. Yeah, perfect.
All right, so we optimized. So, key thing about this case so far is that a lot has gone into optimizing this guy. We got him to stop smoking. We discovered his cardiac issues. He got that treated, and we discovered his osteoporosis, and we got that treated. So now finally he's ready to have his surgery again. That's obviously that was delayed by many months, but that's what you need to do to get good outcomes for these patients. Here's an MRI scan, foraminal stenosis at L3-4 and L4, L5. L5S1 looks partially circularized. So just quickly going through some of the axials. L2-3 some stenosis. L3-4 you can see with the lateral subluxation that he had. That's where the majority of the stenosis is, and you can see fluid in the joints as well. And then he's got some right-sided lateral recess as well as foraminal stenosis at 4-5. And here's a CT representation. Again, you can see partial circularization of that L5, and then the degenerative condition above that.
Yeah, Zishan, I'll just point out here briefly again, this looks like more of a bow C type of deformity. The thoracolumbar junction spine is being much more flexible than the lumbar sacral spine. You've got a transitional vertebra, and that was kind of predictable based on the plain film, but that L5 is a transitional vertebra. But that L3 to S1 is going to be a lot stiffer than that thoracolumbar. So keeping this patient well aligned in the coronal plane is going to be a challenge.
No, absolutely, completely agree. And I think it comes back to, again, maintaining that harmony, maintaining that balance, figuring out how much to correct each segment so that we have a good overall alignment. So I'm going to go to this and maybe have a bit of a discussion here with everyone, comments, discussion before we go on to the final x-ray. So let's talk about the level selection then. Scott, we obviously looked at your case, and while we looked at your case, you connected into the top. What would you guys choose in terms of levels in this guy?
Yeah, I think it's not a super impressive scoliosis, and historical lumbar kyphosis is not that bad. So I think this is a lower thoracic UIV for me. I'd also look because of his high PI, he needs a lot more down low. So I think A lift 3 to 1 is a good idea. And when I'm doing my pelvic screws, I'm just off the bat placing a kickstand screw on the right side, even if I don't need it. It's there, another point of fixation, but I'm sure you're going to have to push this patient over to the left.
I'll
Yeah, I agree with the three. Oh, go ahead, Bob.
I was just going to add, since I'm the MIS guy on the panel, this is actually a dangerous place to try to use MIS technique unless you can really capture that fractional curve effectively. When you start doing stiff inner bodies above the fractional curve, you can really drive that coronal deformity into a worse position. So, not that you can't do it, but you have to be much more thoughtful about executing an MIS approach here. And I agree with Scott. It looks like this patient's got thoracic extension, so there's some capable musculature up there. So I would tend to go to the lower thoracic spine for the
And I'll
extension.
just say, Sig, this might be, we have to measure it out, might be a bow A, which is the real snake in the grass because you're not even thinking about coronal alignment, but his head is 2.5 centimeters to the right. So he comes in not complaining of it. He's going to post op when he's 6 centimeters off to the right. He's going to definitely be complaining about it. So the A's too.
Yeah, that's a really important point. Obi divides it into one and two, but the A, where you're not thinking about the coronal plane, is the one where you can actually throw it off the most. That's the most important balance, right?
Yeah.
Yeah.
And I'll just weigh in on the plan. I certainly agree with the 3 to 1 anterior. That fractional curve is going to be much stiffer than the thoracolumbar curve. There's one where that 5-1 being transitional. I'm not sure you really need anybody there, but certainly get up to 3 with the anterior. And I agree with stopping at the thoracolumbar junction. This would be a T10 or T11 UIV for me. What's difficult to predict is what's going to be the reciprocal kyphosis of that thoracic spine. So when we have these patients who are really hypokyphotic, those are the ones that are the toughest to predict with regard to what happens to the thoracic spine.
Great points. What would you guys do at the top if you're stopping at T9? In terms of, I think the question came up in the chat as well. Someone asked about PJK prevention and tethers and or hooks and other things like that. And we talked about, low PI versus high PI and, having more lordosis up top versus not. What's your take on that? What are we doing at that junction? Are we
Yeah.
making it straight?
Yeah, definitely make it kyphotic, right? Put the anti-PJK band, as some people say. The other thing, and I'm scrolling through that CT with a fine tooth comb, looking for osteophytes, looking for really spondylotic joints that are stiff, that are going to give me some protection. I mean, I'm getting a magnifying glass out to look for a good level to stop at, and then I'm also going to do a tether.
Yeah, I'll just add briefly that I'm going to be using a muscle sparing approach for my UIV. Most typically, or always, I'm going to try and stop at a level that's either neutral or no more than 5 degrees kyphotic to start off with. So that's where I think about T10 versus T11 versus maybe T9. Actually, T9 is a little bit more rare for me. I cement my UIV. And I'm keeping my screws in the straightforward rather than anatomic trajectory. And in this instance, I'm not using a tether routinely. I use the tether for the upper thoracic, but I don't routinely use it at the thoracolumbar.
Bob, anything you want to add before I show the
Yeah,
the
the only thing I've done more recently and still need to analyze it is a fastener type of fixation at the upper instrumented vertebra, similar to cementing, but I've never liked that biologic hit to the bone up there. So it's
Hmm.
just a more rigorous and durable fixation method. And then tethering for me is something I will do if I think the sarcopenic substrate is poor. But if somebody's able to lordose like this or hypokyphose their thoracic spine, then I'll use that muscle preserving midline sparing approach that Sig talked about.
But Sig, you said your top level screws, you like down going?
No, the straightforward rather than the
Really?
anatomic. So the
I'm the
anatomic
opposite.
trajectory is down going or is kind of as if you're using a claw construct. But when those upper screws are more than about 20 degrees kyphotic, that's been associated with more PJK.
That's fascinating. I'm the opposite. I like that screw as far away from the UIV end plate as possible because I don't want it to settle up and get close to the disc. We've shown that with some of our data. I know Hopkins has,
Yeah.
but you make a good point about potential lever arm, but I like them to be very down going.
All right, just in the interest of time, we'll move forward. So I did T10 to the pelvis. I did all posterior. I did not do an interbody at 5-1 because it was sacralized and intra-op appeared to be quite stiff as well. So we decorticated and bone grafted there. And some of the key things that I quickly want to mention here is we had almost 40 degrees here from L3 to S1 just with posterior approach, just with the T-lifts. So I got a lot of lordosis there. And because I'm staying short, and because of his high kyphosis in the thoracic spine, I think I actually paid more attention to, as we talked about before, not getting too much correction in the upper segments. And so you can see that that slight kyphotic bend high up from T10 to T12 almost, and also trying to really ensure that I'm not getting too much from the L1 to L3 segments because I'm stopping at the thoracolumbar junction. I did cement the UIV and UIV plus one, and then I do tend to tether my thoracolumbar patients now. I actually don't tether the ones that I stop at the upper thoracic spine. The reason for that is that I've just found those upper thoracic spinous processes to be really, small and they just break easily. And these, but the lower kind of lumbar thoracic spinous process seem to be a bit more robust. So I tend to, put tether there, to try to get the realignment. So this is his kind of short films, and this is him, overall, basically long films alignment. So comments here. Obviously, we kind of looked at all these things that we talked about.
Looks great.
I think that's a terrific construct. I think it's interesting how, despite what I would consider pretty ideal alignment, not much reciprocal kyphosis. Great. And finally, with regard to preferences for interbodies in the upper lumbar spine, when do we need interbodies, L1, 2, L2, 3?
I almost never use them unless I do a really large decompression for some reason. But almost like at 1, 2, 2, 3, I almost never use interbodies. I mean 3, 4, 4, 5, 5, 1 I will, but 1, 2, 2, 3 I almost never.
I'll say two reasons. If it's an MIS construct, you really need them, and you have to be very careful not to overload dose. So if you have a Rousseli 1 or 2 patient, you have to resist the temptation to put a lordotic implant up there because they tend not to need those, and you can create a PJK problem. And then the other reason I'll use it is if you have erosion or some bony dysmorphism, where you really need to reconstitute a space that has occurred because of erosion into the bone and neutralize that malalignment that's bone related.
Well, I'd like to thank our panelists.